Respiratory 103, Chapter 6. O2 and CO2 Transport. Oxygen is carried in two forms. It can be dissolved in blood plasma, or bound to hemoglobin in red blood cells. Hemoglobin is the main transport of O2. Its normal value is 12 to 16 grams per 100 milliliters. In male it is 14 to 16. In females it is 12 to 15 and in infants it is 14 to 20. One O2 molecule attaches per heme group. Oxyhemoglobin is hemoglobin with O2. And reduced hemoglobin is without O2. Hemoglobin continued. In the ferric state it can't transport O2 due to a changed iron molecule. This is called methemoglobin. In a ferrous state it is able to transport O2 because the iron molecule is unchanged. Hemoglobin S is any altered or mutated hemoglobin mainly referred to in sickle cell. Met can change ferric to ferrous but the only option for hemoglobin S is transfusions. Adult hemoglobin is made up of 4 heme groups that are the pigmented iron-containing non-protein portion, plus 4 amino acid chains that are polypeptide chains that make up globin or protein and consist of 2 identical beta and alpha chains. Fetal hemoglobin is made up of 2 alpha chains, plus 2 gamma chains. And it has an increased attraction to O2. Know these equations. All these equations inside other equations. Knock knock. Who's there? Equations. Also know these normal values. Pulmonary shunting. Oops, one more equation. Pulmonary shunting is the portion of cardiac output moving from the left to the right heart without being exposed to alveolar O2. It divides into absolute, which includes anatomic and capillary shunts, and there's relative shunt. The values of pulmonary shunts are normal, which is below 10%. Abnormal, which is 10 to 20%. Significant lung disease, which is 20 to 30%. And potential life-threatening, which is more than 30%. 3 normal shunts are the Theban drain to the left atrium, which is anatomic. The bronchial drain to pulmonary veins, which is also anatomic. And passed under ventilated alveoli, which is a capillary shunt. These shunts cause 3% of O2 to never reach tissue. So a reading of 100% saturation actually only equals a 97% saturation. Anatomic shunts bypass the alveoli completely. Some causes of this are congenital heart disease, intrapulmonary fistula from chest trauma, and vascular lung tumors. Capillary shunts pass near unventilated alveoli. Some causes of this are collapse, consolidation, or fluid accumulation of the alveoli. Both of these shunts can't be treated with O2. A relative shunt is due to more perfusion than ventilation. Some causes of this are hypoventilation, diffusion defects, and a ventilation-perfusion mismatch due to emphysema, bronchitis, and asthma. Relative shunts can be treated by O2. A venous admixture is a mix of shunted blood and reoxygenated blood distal to the alveoli. It is found downstream in the pulmonary venous system and is usually drawn from the radial artery. Brain damage from cardiac arrest. For every minute 250 milliliters of O2 is lost. Because of this, damage can happen in 4 minutes. Polycythemia causes include a hematocrit level greater than 52% in men or 48% in women, and a hemoglobin level greater than 18.5 in men or 16.5 in women. This can cause thick blood that overworks the heart. Hypoxemia is low O2 in the blood, and normal value is 80 to 100. Mild hypoxemia has value of 60 to 80. Moderate hypoxemia has value of 40 to 60. And severe hypoxemia has value of under 40. Cyanosis is a sign of severe hypoxemia. When assessing, you should check their temperature and their nail beds. Cyanotic patients' blood has at least 5 grams % of reduced hemoglobin. APA O2 of about 30. and about 13 volume% of O2. Hypoxia is low O2 in tissue. Some signs are tachycardia, hypertension, peripheral vasoconstriction, dizziness and confusion. There are 4 types including hypoxic, anemic, circulatory and histotoxic hypoxia. Hypoxic hypoxia is due to low PaO2 that causes low O2 in the tissue. Some causes are a low PaO2 due to hypoventilation or high altitude, diffusion impairment due to interstitial fibrosis or lung disease, pulmonary edema or pneumoconiosis, a ventilation-perfusion mismatch, and pulmonary shunting. Anemic hypoxia is due to low amounts of hemoglobin that can't carry enough O2. Some causes are decreased hemoglobin concentration due to anemia or a hemorrhage, and abnormal hemoglobin such as carboxyhemoglobin or methemoglobin. Circulatory hypoxia is due to low blood flow causing low O2 in the tissue. Some causes are slow blood in shunts. Histotoxic hypoxia is due to tissues not being able to metabolize O2. Some causes are cyanide poisoning, hemoglobin and carbon monoxide poisoning. Carbon monoxide has 200 times greater attraction to hemoglobin than O2 and the bond is relatively stable. This makes carboxyhemoglobin, which blocks O2 from binding. It will give false APaO2 and SO2 reading. So the blood gas analyzer needs a hemoximeter to get a correct reading. The oxyhemoglobin dissociation curve. The flat portion or safety zone has 60 to 100 torr and 90 to 100% hemoglobin saturation. In this portion O2 is loading on hemoglobin in the lungs. The steep portion has 10 to 60 torr, and O2 is unloaded to the tissue. Shifts to the curve. Right shifts mean a decreased affinity for O2 making it harder to bind. Left shifts have the opposite effect. Right shift causes include a decreased pH, an increased pCO2, temperature or DPG. A right shift will affect the P50 by increasing the amount of PO2 needed to reach 50% hemoglobin saturation. Normally P50 is achieved at 27 torr. There are 6 mechanisms of CO2 transport. 3 are in plasma which include carbamino compounds, bicarbs and dissolved carbon monoxide. And 3 are in red blood cells which include carbaminohemoglobin, bicarbs and dissolved CO2. That's all folks. RESP